So if it's okay. Hello everyone. Welcome to the September Lunch and Learns, which for those of you who have students, this is the first Lunch and Learn of the academic year. Welcome to you all. This is a something that I'm really excited to listen to today, and I wanted to formally introduce Dr. Mike Evans. I've worked with Mike, just looking back, probably since 2012, 2013, when we were working on our inaugural pediatric concussion guidelines. At the time, Mike was a practicing inner city primary care physician, and he was chairing a provincial guideline service. And along with those credentials, beyond his expertise in a household full of hockey players, made him an ideal collaborator on a concussion project. Since then, he's built a really incredible and diverse and impactful career. He's a professor of family medicine at the University of Toronto. He's been a physician at the Sochi Olympics. He's been a founder of a health media lab with a massive YouTube presence. He started a film company, and he's the holder of the world's first chair in patient engagement. In 2016, he was recruited to Apple. Some of you may have heard of that company, where he designed population scale better life experience that have been used by more than 1 billion users. That's integrated wearables, AI, behavioral science, storytelling, and nudges. I personally think he's putting in a strong bid to knock off the crown of the world's most interesting man from that Dos Equis commercial guy. So we'll see if they ever reboot that, or Mike, you yourself can reboot that in your media lab. But today's talk, Mike is going to be talking about how we can use technology to strengthen relationships and care, and is going to be drawing on all of his amazing experiences and expertise. In which he's going to talk about how decision making can be changed, how people consult AI, mobile tools and apps, social platforms, mental health supports, and wearables, and how these can maybe help provide better care for the patients that we see and treat. So please join me in a warm welcoming Dr. Mike Evans.
Thanks, Roger. Wow, that makes me sound definitely better than I am. I am still playing beer league hockey. My my kids all played. My two boys were quite good, like D1 types, and they came out and played in my beer league. And I thought they'd want to be on my line, sort of a Gordie Howe situation, but they went on the other team so they could toe drag me like 18 times in the game, and come home to my wife and say, "Dad thought he was going to take the puck off us." Yeah, so a bit of a kind of weird career journey. And I'm coming to you from sort of Silicon Valley. And yeah, so I just want to start. I just threw this slide up like 2 seconds ago. Um, Last night I went and saw the Valkyries play, which is the women's basketball team, and they lost in a buzzer beater. But I took a Waymo, which some of you may or may not know, but it's this driverless taxi. So you hop into the taxi and it goes, "Mike, please put on your seatbelt." And when I first started taking them, it was a little bit like, driving with my 16-year-old daughter, like super hesitant, and it would take you a while to kind of eke out. And now they're incredibly smooth. It's just in San Francisco. They kind of LiDAR'd the whole area, and there's now about 250,000 weekly rides in San Francisco. They have 300 cars. It's going on 24/7. There's 80% less crashes than with humanoids. They've now partnered with Uber to kind of do a hardware software thing. And I just thought it was sort of just a super interesting model. I took a flight the other day with the Waymo guy, and he says, well, initially we had like one person kind of watching each car. So it really wasn't a scalable thing at that point. And now they have one person watching like 5 to 10 cars. And the reason why they had the 1-to-1 ratio is they were just so worried about obviously something crashing, because even though their data is good, it would be such a negative publicity thing. And so it was super incremental and just in one place. And it feels like healthcare is going to be a lot about that. And somebody takes concussions and just kind of rethinks the whole thing. It'll just be super interesting, but there will be some crashes, and there will be some failing fast, and probably more of an entrepreneurial mindset. I'm just going to talk about, I'm not going to talk about medical training, but I am going to talk about how the world's changed a little bit in terms of of, we've had big crises in healthcare, COVID, you know, before COVID, digital was 1% of care. Then it became 70% of care. I don't know. I was just doing a big quality improvement thing with Kaiser last week, and they're up to about 45% care. Kaiser's like the same size as OHIP, and 45% of theirs is digital. Um, I think the way people are kind of informing their health decisions has totally changed. We're now asking AI, and some of it hasn't changed at all. We trust our doctors and we trust our other clinicians, and we trust our mother and whatever, and our good friends. So, super interesting. I'm going to talk a little bit about wearables, combining data and education, AI. I mean, at Apple, we would say, hey, the clinician, sees that patient 2 or 3 times a year, maybe less, maybe more, but we're seeing them 85 times a day. And it's a whole different viewpoint we have. And so just thinking about where we're going, this talk has nothing about concussions, you'll be glad to know, because you're probably sick of that at this point. So, okay, so the next thing is just thinking about algorithms, and the two big kind of departments there, I guess, are how it answers our questions and a kind of our feeds. And I'm just going to talk about the questions. So if Roger was fatigued in 2022, he would ask Google. He would get, a big medicine response, so WebMD or .org, maybe CDC, very generic, very one way. Um, Now he's asking ChatGPT or Perplexity or whatever his generative AI of choice is. It actually answers, like, he can say, I'm a X-year-old male, and it's going to say, okay, instead of just saying a generic answer like, well, your fatigue might be because you're not sleeping well enough, or you're not getting enough activity, or maybe you're depressed or whatever. He'll say, I'm not depressed, but I am having a lot of fatigue, blah, 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 and it'll get more into it. There's actual dialogue. And I can tell you in the future what will be coming. Apple's kept a lot of this stuff, your health information private. But if Roger gives the permission for the AI to go in and look at his medical record, it'll say, "Hey, Roger, you're actually low thyroid. That actually causes fatigue, and you haven't been checked in 2 years. And that might be our first starting point to figure out why you're fatigued. And here's a depression, PHQ-9 or whatever, because that might be second in line." So super interesting where that's going. I'm giving it a kind of 3.5 star thing because it's just so uncharted, and we've all seen the hallucination. And I think as ourselves with users, like, it's a little bit like reading the news when you know a lot about a topic. You see the answer sometimes and you're like, okay, we're kind of missing it. It's a little bit like research. It's a lot about asking the right question, I would say. Um, but the growth is just, I mean, it's mind-boggling. Like, if you look at daily searches, so in 2022, 8.5 billion searches a day on Google, zero on ChatGPT. 2025, there's 40 million searches a day. Probably getting up to half of them now are people answering health questions. 2022 in November, zero. Now there's a billion, people using AI to answer their questions. So, that's more than Fortnite. So incredible growth. And then you guys have probably seen this data. It's definitely got some caveats. So this is uh, they put together teams of pediatrics, internal medicine, public health, primary care, oncology, emerge, and they looked at a whole bunch of different questions, and then they compared physician questions to physician answers to chatbot answers. And you can see, you want to be farther to the right in these, quality wise and empathy wise. Um, the chatbot scored better than the doctor. Now, big caveats here. the doctors that they were using here were, they were answering it on questions on Reddit. So I'm not sure doctors answering Reddit is the gold standard for healthcare questions. They're not seeing your health record, they're not knowing you, et cetera, et cetera. But still super interesting. Empathy was also probably big caveat is the average physician answer was like 50 words and the average chatbot answer was 250 words. So I'm not sure if it was super blinded, but still on an empathy score, they scored higher because it's easier for them to generate more words. And so I'm saying, sure, there's caveats here, but I think it's just telling us that some of these answers are getting very, very good. Um, this is just, I don't know what it's like at U of T or where you guys are wandering around, but when I wander around with the med students at Stanford, first of all, they're taking all their notes from whatever class that day and they're uploading it in a Notebook LM. So all their slides, the web pages that the teacher recommends, PDFs, and they can actually kind of customize that and say, I don't really understand the Krebs cycle or whatever it is in that thing, and they can really drill in on that. They can quickly turn it in to a podcast. It's kind of fun. I don't know if you guys have played with those, but you can make it funny, or you can make an interview, or you can change the genders or whatever. It's actually kind of a little bit crappy, so it's crappy enough that you actually remember things. But when you're riding around on your bike, you can see all that, and then I would never do this, but they put into flashcards with Anki, and that has a USMLE overlap, so they can actually see what they're doing. And then they can use ChatGPT and say, okay, can you present as a 60-year-old woman requesting a bone density exam? And it would kind of get into, okay, how are we going to counsel this person if she has no risk factor and maybe she wants to wait till she's 65 and understanding, time and osteoporosis, or maybe she's got some risk factors and she should be screened earlier. And then they can ask ChatGPT to kind of be the, present as they're attending and anticipate the questions that she would have for me. So super interesting. And of course, there's lots of different, Pathway AI is very guideline driven, kind of like an up to date, but they've got a nice AI thing where you can ask questions instead of just looking at the app. So super, super. And so a medical student a year ago wasn't doing this. Like it's completely changed how people are learning. So super interesting. Next up is social and just, how that's changed over time. And so that's the bottom of these two. I think pre-COVID, there were, health influencers. I might have been one of them. But I really think that changed in COVID. And I actually think in COVID it was kind of a good thing. Like we were all following, we might have been following Fauci, but we were following some local hotshot infectious disease epidemiologist who was saying, gosh, I don't know the perfect answer for this, but looking at the data, I think we should be getting our shots here, or we should be wearing a mask there, or whatever. And we actually really liked that kind of POV and the personality. And obviously, it was much more agile than big medicine, and just it really was actually kind of a good thing. And now, of course, it's kind of morphed into a bad thing. The incentives are super malaligned. So things that are false kind of travel probably 10 times as fast as things that are true. They're obviously interesting, and they don't understand. I was watching somebody the other day and they were talking about, well, we're now using way more suntan lotion and going, wearing hats, and still the melanoma rates are increasing. And I'm like, the melanoma that you're seeing in your clinic is from a burn 20 years ago. It's these are very slow evolving. So they don't understand some of the basics there. So I'm giving that a kind of 1 out of 5 Yelp experience. I do think there's, some peer-to-peer stuff that's super interesting. And it's obviously embedded in this larger, I mean, there's obviously a pretty good argument that it's a bit of a source code for so much of our divisiveness now and our echo boxes. It's also kind of funny. I I mistakenly loved a wiener dog video, and I admit to watching a whole video of goats clearing land, and now my whole feed is wiener dogs and goats. But so it is that as well. So I guess the question is, so if they're getting health influenced, how evidence-based is that? So I took two examples. There's actually, it seems like every PhD student's doing this now. So the first case study was looking at ADHD. It was actually UBC psychiatrist, and they took the top 100 TikTok videos and they examined them for accuracy and distribution. So finding number one is that they're uh, killing it distribution-wise. Like if the CDC is a bad example these days, but if the Concussion Society of Canada put out a video compared to some big health influencer, like these were shared on average 31,000 times and had 2.8 million views each. So incredible. So they're definitely winning on that. When they looked at the evidence, 80% wasn't science-based, 52% misleading. Probably some benefit in terms of like, here's my personal experience with that and some of the peer-to-peer stuff. Nutrition, also just looking at TikTok, but just looking at Gen Z and millennial, which I think is up to 40 or 45. And it used AI to look at 67,000 videos and compared to, guideline based evidence from WHO or USDA or wherever. So the first thing, again, lots of use. 87% of those Gen Z millennials were using it for nutrition health advice. 57% adopted, crazy detox, whatever diets, and 31% reported having adverse effects from those diets, and definitely kind of prioritizing viral popularity over credentials. So this is sort of something interesting for us in academic medicine. And I think it's also important that we don't forget, like everybody's down on big pharma, uh, but the wellness industry quadruples. Like it's just a massive, massive industry. And I I'm guessing that you guys see that in concussions in a massive way, like people edging into concussion care with whatever supplement or whatever, you just have to do this and that. So because they beat their concussion that way. So super interesting, the forces at play. Okay, so just shifting gears, I do think patient education is about to get a lot more horsepower, but just to stand back a little bit, I actually think we don't think too well about where we should kind of focus our energy. So the first trial here was a famous trial looking at the kind of ecology of medical practice by Larry Green. It was a great study. And, I would use this quite often in my talks back then saying, hey, 1% of care happens in hospitals. You know, at that time, 39% was happening in primary care, but still the majority were happening at home. And so I just feel like when we're investing in helping people, we invest in the wrong location, I guess you could say. We don't help people where they are. And then, as I've kind of already said, in COVID, digital care went from 1 to 70 and maybe settling in at 40. Now, Kaiser's a hospital-based, whatever. Just to jump to the next one, I think I'm working with a company called Galileo. The guy who started, Tom Lee, started One Medical. And then he wanted that was more sort of aimed at urban professionals, I would say. Galileo is aimed at everybody and especially focused on low income patients. And, they're taking care of like 85-90% of their problems. There's still a selection bias there, I would say, against not super complexity, and then they built up a whole home care thing because a lot of the Medicaid patients need that. So super interesting, and how that's changing. Even like this isn't as big in Canada, but we built so you can take all your health data and put it into the phone, and it comes up in an Apple experience. And you can do that in Canada. You just don't have as much drive for that because you're going to one care provider. But in the US, you're going to seven different care providers. So having it all in one place is super interesting. So it's all kind of changing there. And I think a big part of that is just this. If I tell Roger that he needs to maybe not have that pint of Guinness just before he's going to bed, he's like, okay, that makes sense. And I say, it'll make you get up and pee, or it drops your ADH a bit, or but then if he looks on his sleep app and it says, oh, his sleep architecture is really not doing well that night, like he can see it in himself, that's a whole different kettle of fish. And I think that's super interesting when you can kind of combine those two things. So, and then of course, now we're combining it, patient education is a little bit like evidence-based medicine. It's sort of the critical platform, but it's insufficient. Connecting with people with their own data. We're doing some super interesting stuff with blood pressure data, and how to kind of message that. And I'll talk about an example we did with asthma. And then prescribing an app and sort of coaching people with AI, whether that's with an agent or some other things that we can actually talk a little bit about. But having a shared dashboard is super interesting. We do a lot of work with that where people can share their dashboard with their clinicians or with their loved ones. And it actually is really interesting when we're all looking at the same blood pressure readings or asthma, scores or whatever. So I'm just going to talk a little bit about wearables. And I think this is just a slide that I made up that I just think doesn't get talked about enough, but, and it has to do with wearable mindsets. All these people are right. So you have your data denier. So this person says, why do I need a watch or a ring or a whatever? I know when I sleep well and when I don't, and when I exercise and when I don't. And I'm just not interested. They may be interested, like if I built a thing, they had Parkinson's or something, and I could improve their outcomes, they may be interested. But, I think that's fine. I think a bigger population than we think is sort of data anxious. And when they're told, oh, you need to stand or you haven't got enough steps, they get kind of fixated on that. And that actually is a pretty stressful experience for them. And them not owning a watch is probably just good self-awareness. And I think that's totally great too. They may be interested in a data light experience, maybe. Data light, I think, is our biggest group. And I'm writing a book about this, like what's your dashboard? And I think this is the biggest group. And they just want, like, just tell me three or four things. Like, is it VO2 max? Is it my sleep? Is it some quality of life, mood calibration? Is it steps? What are the things, that kind of three things I should be following? And maybe they're throwing in one thing that's sort of more interesting to them, like time with family or time watching TV or PHQ-9 or something. But they just want a very simple dashboard and just want to focus on a few things. And then there's data devotees. That's probably mostly what we're focused in on in places like Apple. They're great. Like, they're running all sorts of life experiments all the time, but they're also super prone to, oh my God, my, REM sleep went down 2% last night. There's actually a great trial out of, I think it's Oxford. It's not too big. It's like 70 people. So sorry, I keep picking on you, Roger. Say it's 100 Rogers and they're averaging 6.1 hours a night. So we're supposed to get 7.1 hours. And so half the Rogers got the feedback, Roger, you're only sleeping 6.1 hours a night. You kind of suck. You got to do something about that. That's going to have this ripple effect on your life that's super positive, blah, blah, blah. The other 50 Rogers got, hey, Roger, 6.1 hours. You're a stud. You're great. We love you. Way to go. And then they've tracked those people, and the people that got the positive feedback, even though they all had the same TST, total sleep time, they actually had less fatigue, better work productivity. So do you see what I'm saying? It's very much a mindset thing. We see that when we counsel people about sleep is that they have that bad night and they think that's super unusual, but that's just, hey, you had a bad night. It's kind of normal, no matter what we do, to have the occasional bad night, and let's move on. So just giving people data is actually a thing, and so how we like a lot of people, the Oura Ring is probably a little bit better sleep experience. I mean, Apple's just come out with a new one. But people liked it a bit more. But it also was giving people, they felt kind of negative all the time. And so they stopped wearing them. And it's just sort of super interesting, all that stuff. Whereas Apple's just positive, probably to a fault. So remote monitoring, super interesting. So I was there the first day that we got that kind of AFib thing on our screen. It was like super faint. It's kind of cool. AFib comes and goes for most people at the beginning. And, we had like a 96% sensitivity because we were tracking all the time, and a 24-hour Holter wasn't doing that. So our sensitivity was 96%, and detection rate in the clinic was maybe 34%. But now in terms of kind of remote monitoring, we have like AFib burden. So we can say, hey, Roger, you're only in AFib like 2% of the time. And that's actually interesting for Roger. Like when people have AFib, they're like, is this my AFib? Or like, am I feeling this way because of my AFib? Or is I'm feeling this way because I'm whatever, just hit 4 bad golf shots. And then also we'll tell Roger, hey, you're, I don't know, in AFib 60% of the time. So you better go visit Roger in the emerge and get ablation or something. And so it's super interesting that way. Cardiac rehab at this, just helping them with this. Like about 40% of people were showing up. I think we all know what cardiac rehab is. It's like you're meeting in the hospital, maybe 12 times over a couple of weeks. You see the pharmacist and the physio and the doctor and whatever. And you kind of build a little bit of a community, but only 40% were showing up and less women were showing up. And then when we did a remote version, not with Apple Watch, but with Fitbit. They really focused in on the caseworker who was running it. Like they were really connected to them. They actually lied quite a bit on how much activity they were doing. But we basically had the same outcomes as the in-person, but 80% were attending. So, it's just, if you have very severe cardiac problems, you probably need to go in hospital. And some people just like the community more, I think. And then other people, it's just more accessible when you can do it from home. So super interesting. There's things we can do at home actually that in some ways are better. So really cool. Parkinson's, like, we can really check because we can see your tremor and we can see your gait. Are you scissoring? We can look at your speech. We can obviously see your activity. We have a million cognition measurement stuff happening at Apple. And then, with Parkinson's, it's on off. And so we can kind of customize with people. And so that's super interesting. And maybe 3/4 are saying they improved their care. And then you can also see, you can use up less healthcare resources. This is kind of a funny paper done in Holland with my Parkinson's coach. And they're like, well, in the rest of the world, you can't see your neurologist 4 times a year, but in Holland you can. And so when we prescribed the watch and track people, we actually reduced visits by about a third. So I actually think we get a better picture of what's going on than when you're in the clinic, because you're only seeing the clinic that one time, where they're at. And these things are so variable. So I think that's just super interesting and something for you guys to think about. This is just a little bit obvious, but if you're thinking about it, I mean, obviously you don't have the horsepower of Apple, but this is Apple Fitness. You click on the button and it's just so easy. It's just like, let's go. And you just do it. And this person actually pops up in the screen and they start running you through a thing. And then your heart rates, if you have a watch, is coming up there. And then it's super attractive. You're seeing these people and like the guy in the center's the middle guy running it, but the people on the sides, one of them's doing an easier routine and one of them's doing a more advanced routine. And you can sort of say, okay, I'm the easy routine person, or I'm the more advanced routine person, or whatever. So you can kind of it's more flexible and forgiving. You can join with your friends. So Roger and I can do it together, and he comes up on my screen, and we can compare notes. And Roger will find out that I can not even get close to touching my toes, and so on and so forth. And then this hasn't come out yet, but well, it's announced, but it's going to be much more personalized planning and feedback, so you can kind of customize your whole routine about all that. So if you're thinking about how you're going to build something for concussion patients in the future, making it these things, which you can make pretty easily, is kind of pretty critical, I think. So just to think about that, prescribing apps for self-management. So that's if somebody comes into your clinic and you say, okay, I have um, the Super U of T, whatever concussion app, and you prescribe that to your patient, and they're using that, and it has all these different features. So there's a dashboard on top. You can set it up how you want to set it up, kind of thing. So what's a good example? So, like if you look at Noom, do you guys know what Noom is? That's the one for weight management kind of thing. And so there's these sort of things about, tracking your calories and looking at your actual weight, and then they have all these educational things. Well, it's interesting watching people how much they differently set that up. They don't want to, you can actually talk to somebody. A lot of people don't want to talk to anybody at all. They just want to keep in a very small thing. Others want every service. So it's very interesting. You can build an education, and obviously I'm biased, but whiteboards work really well with that. And I'll show you an example of that. Looking at the bigger picture, pain points. Yeah. And so, but you can see there's a lot that goes into these things. And when we sort of are thinking about the basics, though, so first is, what's the signal? So what are you trying to collect with concussion? So Apple's got like 80 trials going on about, hey, can we predict, I don't know, so you're trying to predict depression. Well, we're looking at how much people are moving around, the poverty of their messages, how often they're messaging. This is obviously in a trial atmosphere we're doing with UCLA. We're looking at the tone of their messages. Um, like it's super interesting. Like I was working on Siri for a couple of years, like one day a week, and somebody said, "Hey, we think we're getting like 20,000 messages a day in the U.S. about being suicidal." And I'm like, "What?" And so I kind of freaked out, and I said, "Can we just understand that?" So obviously, privacy-wise, we actually couldn't get to true ground truth because we can't see what's going on really with people. So I had a postdoc for a year, and she was amazing, and she just listened to them. I'm just talking about one thing, just listening, and seeing how they interacted and why Siri was triggered that way. And she estimated about a quarter of those 20,000 calls were truly people in trouble, and three-quarters were just false positives. Siri was totally reading it wrong. And so I just put on a thing that says to all 20,000 people, hey, if you're struggling, here's your local suicide hotline. And so three-quarters of those people, it's a waste of time. They're like, why is Siri telling me this? But I have 900 people a day connecting with the suicide hotline every single day. So that's kind of a super interesting, like when you just think of the scale of this only happened in the US, but they're going to expand it, I'm sure. But just so interesting. Explaining things to people. So what I call what, so what, now what. So Apple's good at the what. They don't do much on the so what, now what, whereas you guys could do much better job that way. Coaching, nudges, progress bars. I think we talked about with Ura and stuff. It's a very complicated game. I I have mixed feelings about this, but I kind of get the sort of MBA maxim that if it's not measured, it's not changed. And so I do think there's some interesting stuff there. I just don't think everything can be measured. But and then just connecting that to the bigger picture of people's lives. I mean, the reality of behavior changes. It has to become a routine. So So I'm just going to give you one example. This is just a trial we did that just got published in JAMA, 900-person randomized control trial, which is huge for asthma. We gave them all, this is with Anthem and UC Irvine. We gave them all an Apple Watch and what's called a Bedit. We've since wound that down, but that was a company out of Finland, and it's just a plasmograph you put across the bed, and we could detect nighttime coughing and if people are getting up at night and so on and so forth. And so half the group got a digital experience that I'll show you, and half the group got basically just usual care and no digital tools. So by digital care, they kind of did three big things. So one is logging. So just the simple question, what were your symptoms like today? The next thing, and this was super interesting, was just alerts. So it would say, hey, Roger, your activity has gone down by over 50% the last 2 days. Your resting heart rate's gone up. So we think it's not Apple thing. It's actually based on the Seattle flu studies, but that heart rate is actually a super strong predictor of respiratory tract infections. And combine that with O2 sats, we actually can. That was one of our things we were obviously looking at to see if we could predict respiratory infections. And we could also scrape in AQI, which is air quality index from Apple Maps, and if it went over 100. And by the way, the more personalized you made that, so if I told Roger the AQI went up to 150 in Ottawa, he was like, okay. If I told him his O2 sats dropped 4% last night, he's like, okay. Now we're cooking with gas. So super interesting. The more personalized you can make that message. And then asthma has a huge educational lift, I would say. Like a difference in the trial with high income people and African Americans, which is a big learning thing. That's a whole nother story. We're doing this sort of qualitative thing with that. But the super interesting thing, and probably kind of the only study you could do in the US, is that the Medicaid patients actually reduced emergency visits by 42%, which is massive. And I just think that's super interesting because we often think of health tech for like tech bros and rich people. But if we give people the tools that are kind of low income and it's self-managed themselves, they actually can figure it all out themselves. We just have to do a better job of going to where they are. So super interesting. And then I'm just going to finish with this, just mental health. I don't have the answer here, but if you look at people using apps for mental health, only about 3% are using it after 30 days. When you look at AI, this is just the stupidest thing, but this guy did it. It was in the Harvard Business Review, and I just find therapy and companionship are two totally different things. And when I looked at this trial, it's actually Reddit users, which are typically male and educated, and obviously more likely to use AI as therapy. But it could be the canary in the coal mine because I do think there's some really interesting things about using AI for mental health. I was just giving a speech in Boston, and a guy was saying where people were running into problems were when they were treating it like a psychiatrist or their best friend or whatever. But if they treat it like a life coach, it seemed to do okay. So I just think this is just super interesting. And like I say, I don't have the answers here, but when you think about AI mental health, you're like, oh, well, that can't work because it's not a normal therapeutic relationship. There's no oversight. It's there. We've all heard bad hallucination stories. Is privacy okay? It's not integrated into their care. The users are overestimating the therapeutic ability. But I ran a trial on domestic violence in my waiting room, and people were much more honest with the iPad than they were with trained domestic violence workers. It doesn't discriminate. It's completely free. Like think about rural areas. There's probably one mental health worker for every 800 people in North America. Does it know user? Does it not know user? I don't know which is better. And if you treat it as a life coach, so I'm just saying, I'm not saying we should do this. I'm in a group that's sort of thinking this through now. It's just super interesting. So, okay, that's kind of it for me.